Welcome, everyone. Let me talk about my PhD thesis, the role of regional anesthetic techniques in enhancing recovery after cardiac surgery. Up to a third of the patients after cardiac surgery experience severe pain requiring high doses of opiate analgesics. It is well documented that opiates can slow down the recovery process and can lead to several complications. Therefore, the need of opiate-sparing analgesia is crucial. Our systematic review and meta-analysis showed that additional thoracic plain blocks can reduce pain by 25% and can reduce the opiate consumption up to 40% without increasing the adverse events. Therefore, they should be included in the daily cardiac analgesia practice, and the enhanced recovery after cardiac surgery guideline should be revised based on our results. My name is Tünde Szalay-Frank. My vision is that regional anesthetic techniques become part of enhanced recovery guideline after cardiac surgery, and my mission is to take an active part in it as a researcher and a clinician as well. In order to achieve my goals, we launched two projects last fall, both of them investigating the several possible effects of additional thoracic fascial plain blocks. My first project is investigating the safety and efficacy of these additional plain blocks in patients undergoing cardiac surgery. We know that several cardiac surgeries are performed yearly, and although the perioperative mortality is pretty low, up to a third of these patients can experience some kind of an adverse event, and pain is one of these morbidities. We know that adequate pain management has a pivotal role in enhancing recovery, and we also know that cardiac surgeries are very painful, even the minimally invasive ones, and therefore cardiac analgesia is traditionally opiate-based. We also know that additional fascial plain blocks are already part of enhanced recovery protocols for other types of surgeries, yet their role in cardiac settings remains unclear. As you can see on the picture, there are several types of fascial plain blocks which can be performed on the thorax based on the site of the surgical incision. The administration of the local anesthetic can be done by a single-shot injection or by placement of a catheter. Both of these procedures are done by ultrasound guidance, therefore the rate of adverse events is very low. Our aim is to investigate whether this block can be safe and effective in cardiac surgical patients. Our clinical question is the following: do additional TPBs enhance recovery after cardiac surgery compared to conventional analgesia? We were using the PICO framework. We were investigating patients undergoing cardiac surgeries. Our intervention is adding thoracic plain blocks to the conventional analgesia, and our comparator is the latter. Our primary outcomes are postoperative complications such as pain, surgical site infection, length of ICU and hospital stay, and our secondary outcomes are opiate consumption and time to mobilization. And we are hypothesizing that TPBs enhance the recovery after cardiac surgeries, and we are implying that they should be included in the daily cardiac analgetic practice. We conducted our search in 3 databases. The search key contained of 2 domains, the first one referring to the patient population, the second one to the intervention. First, we found more than 14,000 results, and after the selection procedure, we ended up with 79. Right now, we are in the grading phase and the writing of the manuscript, which is planned to be finished by the end of September. Let me show you my results. The first one is the postoperative pain measured at the 12th postoperative hour at rest. The pain is measured either in visual analog or numerical rating scale, which are both cases ranging from 0 to 10, where 0 means no pain and 10 means the worst pain ever experienced. We are comparing mean differences, and we are comparing 2 patient groups. The first group receives additional plain blocks, and the other one only conventional analgesia. We made some subgroups as well. Here you can see the first subgroup is when the patients received the block before the surgical incision, and the second one when they received it at the end of the surgery. Here you can see the pooled mean difference, which is minus 1.15. That means that those patients who received the block, they experienced by 1 point less pain on the visual analog scale, which is mathematically significant. The second outcome is also the postoperative pain measured while coughing. The subgroups, the patient population, and the scale where pain was measured is also the same. And here you can see that the pooled mean difference is minus 1.34, which means that the patients who received the block experienced by 1 point less pain while coughing, which is also mathematically significant. On both slides, you could see that the heterogeneity is pretty high, which could be due to the several surgical types of surgeries included and the several blocks included in our analysis. Our last result side is the intraoperative fentanyl consumption measured in micrograms. We are also comparing the same patient populations. The same subgrouping was made. The second one is just out of curiosity because we did not expect any difference when the block is performed at the end of surgery. So let's focus on the third one. The pool result here is, as you can see, minus 271.38, which means that the patients who received the block before the surgery required much less fentanyl during the intraoperative period. And in the light of this, we can say that the former result can be also clinically significant because the patient required much less opiates to reach the approximately same level of pain after the operation. Our study has strengths and limitations. We only included randomized controlled trials, and we, despite the high heterogeneity, we found consistent results, and we could include high number of patients. Although we have some limitations as well, we have very limited data on the minimally invasive procedures, and the block-related complications and the potential confounders are in several articles poorly reported. But we can conclude that TPBs are safe and effective opiate-sparing methods. Therefore, they should be standard of care in cardiac analgesia. But we are implying that the optimal opiate-sparing method for minimally invasive procedures should be further investigated. Let's move on to my second project. It is investigating the effect of TPBs on the respiratory function parameters after cardiac surgery, which is planned to be an RCT. We know that respiratory complications are quite common after cardiac surgeries, and although the etiology is multifactorial, pain can be one of the main causes. As you can see on the diagram at the bottom of the slide, which is a study comparing or searching the connection between the pain and respiratory function parameters, you can see where the patients are experiencing severe pain, then the respiratory function is deteriorated, but when the pain becomes moderate, then the respiratory function is improving. In the setting of this thoracic fascial plane blocks in cardiac patients, it was not really thoroughly investigated. So our aim is to design a randomized controlled study. We are planning to use the PICO framework here as well, and our hypothesis is that the impairment of the respiratory parameters is lower with additional TPBs compared to conventional analgesia only. In summary, we are planning to submit our first project this fall and the second project next spring. And I would like to close my presentation with a quote from Marie Curie: "Nothing in life is to be feared, it is only to be understood." Thank you for your kind attention.
Congrats, Tünde, on your presentation. Is there any recommendation to do the plain blocks right now in the guideline, or is it going to be a completely new addition to the procedure of heart surgeries?
No, thank you for the question. These plain blocks are not even mentioned in the current guidelines, so it would be a new feature there.
Yeah, okay, thank you.
Okay, my question would be, how about your other outcomes? About, you said in the PICO slide or something, that it's not only pain what you are looking for, but also bleeding and infection or so?
Yes, thank you for the question. We looked into the other adverse events. We have at least, I don't know, more than 30 outcomes and 30 forest plots. As I told you, that these adverse events were not really well reported in most of the articles, or when they are reported, they are not really well described. I mean, that can be like respiratory depression, but why is it? I mean, it can be due to opiate effect, or it can be due to very many other things. So it was really hard to make a proper comparison. And mainly we have data on the adverse events related to the high opiate requirements, but they are also significant.
Okay, my other question would be that if I understood that correctly, the blocks were able to decrease the opiate requirement during surgery, and yes. What about the postoperative time?
Yeah, there is also a decrease in the opiate requirement of those for those patients who received before a block, but it is only significant in the first 12 hours. Afterwards, we did not find any significant difference, even in those even not in those patient population where they got a catheter and they received the local anesthetic continuously. Maybe it can be due to misplacement of a catheter or the improper dosage, or we don't really know that yet. But after the 12th hour, we did not detect any significant difference between the opiate consumption. And that can be due to the length. I mean, these blocks usually last, the effect of these blocks, of a single shot block, usually lasts for 12 to a maximum 16 hours. So maybe that's why.
Okay, and would it make sense to redo the block?
Yes, of course. In these studies, there were only a few where they repeated the block after a time period, but I guess it was only 2 or 3 of those studies. In my daily practice, we repeat it after 12 hours. So, but I only know my department and what we do. I don't know. Whereas how they do it, but it would make sense, definitely.